at lunchtime, you're welcome to go for a few laps with Dr. Wright. So our next speaker is Dr. Janet Stanford, who's a epidemiologist in the Public Health Science Division here at Fred Hutchinson and also at the University of Washington. And she truly is a world leader in understanding risk for both the development of prostate cancer, including environmental and genetic, as well as progression. So Janet's going to tell us about her work today. Janet.
Thank you, Pete, and good morning. That was a nice intro from Dr. Etzioni as well as Dr. Wright about some of the concepts that I want to share with you this morning. So some of the work we've been doing recently relates to the question of whether or not there is etiologic heterogeneity in prostate cancer. We've known this as a factor that's important in breast cancer for at least 30 years now, but only recently have we begun to look at prostate cancer. And when we talk about etiologic heterogeneity, well, etiology, as you know, is the causes of cancer, and these could be environmental, lifestyle, or your inherited genetic background, acting alone or in combination. Heterogeneous just means that things are different or distinct. Things are not like each other. So when I talk about the concept of etiologic heterogeneity, what this means is that there are different causes or different groups of risk factors that are responsible for the development of specific and unique subtypes of cancer. Now, at the time of diagnosis, about 95% of all prostate tumors are what we call adenocarcinomas. And up until recently, what we've considered these to be is a single etiologic, common etiologic factors responsible for these tumors that were thought to be representative of a single type of biological entity. But with more recent work from the molecular standpoint, we've been able to look under the hood, if you will, and see that these are not all the same. All these tumors are not created the same. And so now we can divide these up into unique molecular subtypes and look at whether there are specific risk factors that are associated with these distinct molecular subtypes of prostate cancer. And one of the particular subtypes that we've been interested in is what's called the TMPRSS2 ERG, or T2E Gene Fusion prostate cancers. This T2E Gene Fusion is found in about 50% of prostate cancers. The TMPRSS2 gene actually is an androgen-regulated gene that's highly expressed in the prostate. ERG is an oncogene that codes for a transcription factor that's involved in the cell proliferation or drives cell division in the prostate. We know that this fusion occurs, it's thought to be primarily due to enhanced androgen signaling, but what happens with androgen ramping up the activity of this oncogene is that there's really an increase in the growth of cancer cells in the prostate. So we were interested in whether or not these two types of prostate cancer, those with and without the fusion protein, might have different risk factor profiles. And to do this work, we took prostate cancer tumor tissue collected at the time of surgery and then used a technique called FISH to determine whether or not the tumor tissue had this fusion protein. And what you can see is that about 52% of patients in this group did have evidence of the fusion protein. Patients that had T2E positive tumors tended on average to be about 2 years younger. Let's see. 2 years younger at the time of diagnosis compared to patients that didn't have the fusion protein. In addition, the patients that had T2E positive tumors were more likely to be of European ancestry as opposed to African ancestry. The tumors in these patients that had the fusion positive evidence also tended to have lower Gleason scores, and the patients tended to have lower PSA levels at the time of diagnosis. Now, I want to provide you with 3 examples of why we think there is etiologic heterogeneity in prostate cancer based on looking at our first molecular marker, the T2E fusion status. And the first example has to do with obesity, and Dr. Wright has given a great intro to the effects of obesity on prostate in relationship to prostate cancer risk. And we know that compared to normal men, obese men have lower levels of circulating androgens, and androgens are very important as a driver for cell proliferation in the prostate. And so on this slide, what we've done is we've looked at quartiles of body mass index, which is a measure of body fat. And what we've broken down are the patients shown in the green bars that had T2E negative prostate tumors. Shown in the blue bars are those patients that had evidence of the T2E fusion genes. And compared to men who were normal weight, shown here with a relative risk of 1, where there's no association, what you can see is that there's a slight reduction in the risk of T2E negative prostate cancer in men that are obese. This is the 4th quartile compared to the 1st quartile of BMI. But what you can see for the T2E positive prostate cancers is that there's a significantly lower risk of developing fusion positive disease in men who are obese. And this slide just summarizes those numbers for you. For each of these groups of prostate cancer patients, those with T2E negative tumors and T2E positive tumors, to look at their risk of developing prostate cancer, we've compared them to a group of normal controls, and these are men from the same population without a history of prostate cancer and their distribution of body mass index. And what you can see is that for men who are obese, 4th quartile of the BMI versus the 1st quartile, there's an actual significant 34% reduction in their risk of developing fusion-positive prostate cancer. The second example I'd like to share with you has to do with aspirin use. We asked men about their aspirin use and whether it was low dose or the baby aspirin versus regular aspirin. It didn't really matter. And this is work that was led by Dr. Wright, working with my group. We know that aspirin reduces both inflammation as well as oxidative stress. Both of those things may actually be involved in both increasing cell proliferation, and that provides opportunities for there to be DNA damage and a lack of the ability of the machinery to appropriately repair the DNA damage. So we thought if we could reduce inflammation and oxidative stress, one might actually see fewer T2E fusion events. So shown on this slide is the relative risk of prostate cancer according to the duration of aspirin use. And what you see in the green bars is that there's no real pattern of risk for the T2E negative patients. However, when we looked at the T2E positive prostate cancer patients, you see this linear decline in the risk of developing T2E fusion positive disease based on increasing duration of regular aspirin use. Shown on this slide are the actual numbers, and in fact, it turns out that if you used aspirin on a regular basis for about 5 or more years, there's a significant, about 50% reduction in the risk of developing the fusion-positive type of prostate cancer. Now, the third example I want to share with you came out of some work that we were doing on profiling the same set of prostate cancer tumors genome-wide for changes in DNA methylation in those tumors. And what you can see on the left, under the green bars, each of these vertical lines represents a tumor from a patient that had T2E negative prostate cancer. Under the red bar here, each vertical line represents a patient whose tumor had the T2E fusion. And you can see that from an epigenetic standpoint, these tumors look very different in terms of their epigenetic profile. And one of the genes that was significantly differentially methylated that came out of this analysis is a calcium channel signaling gene called CACNA1D, where we had evidence that there were multiple sites in this gene that were hypomethylated in patients who had the T2E fusion positive prostate cancer compared to those that were T2E negative. We know that androgens are involved in calcium and mediate calcium signaling. We know that increased calcium signaling can lead to increases in cell proliferation. So we're very interested in this particular result because this gene codes for an L-type protein that is the target of calcium channel blocking drugs that are frequently given to patients for the control of high blood pressure. So we wondered if actually use of these medications might reduce the risk of T2E fusion positive prostate cancer. And again, you can see here in the green bars, compared to the men who didn't use these medications, men who did use the medications, there was no difference in the risk for developing T2E negative prostate cancer. However, the blue bars show that if you used calcium channel blocking agents, your risk of developing T2E fusion positive prostate cancer was dramatically reduced. And looking at the actual numbers, this resulted in about a 61% lower risk of T2E positive prostate cancer in men who were using these calcium channel blocking medications versus those that did not. Again, no relationship in terms of risk of the T2E negative type prostate cancer. So overall, based on these three examples, as well as a number of other very recently published papers, it's turning out that there's evolving evidence for etiologic heterogeneity in prostate cancer. We believe that this is an important step that's going to help us understand better the etiology of prostate cancer, because now we've had a challenge finding consistent risk factors based on environmental and lifestyle factors, and some of that inconsistency from study to study may be due to the fact that we've treated all these cancers as if they were the same, and now we know that they're not, and we can begin to look at risk factor profiles for the different molecular subtypes of the disease. In doing so, we hope that eventually we'll gain new insights on the causal pathways and novel mechanisms involved that could be translated into better ways to prevent prostate cancer in the future. Thank you.
Thanks, Janet. So our final speaker for the morning session before we break and have a Q&A is Dr. John Gore, who's a urologist, another surgeon from the Department of Urology at the University of Washington. And Dr. Gore has been very interested in understanding and improving access to care and also evaluating quality of care, particularly around surgical outcomes. And he is also interested in helping to understand and manage side effects of treatment. So, Dr. Gore.
Thank you, Dr. Nelson, and good morning, everybody. I want to talk about some efforts that we've been working on for the last several years that are about to be brought into a very large audience, both locally, nationally, and globally. And it emanates from a concept called user-centered design, which you might also hear these terms like human-computer interaction, human-computer design, human-centered design. And it's this idea that if we want to build new tools, it's really important to engage the users of those tools as we build them, so that our end product, our final product, is something that we know that target user can use. So in the case of what I'm going to talk about here, our user is the patient. And so there's this new concept of patient-centered outcomes research that is shockingly a fairly new way to consider how we would approach research. And part of that idea is that our research ideas come from patients, our research designs are created in partnership with patients, and then ideally our end products are usable by patients. So why is that important in prostate cancer? Well, we know that in terms of the outcomes of prostate cancer treatment and the side effects of prostate cancer treatment, it's one thing for me to ask you how you're doing and then come up with my synthesis of how I think you're doing. It's another thing for you to tell me how you're doing on a more anonymized report. And so this is work from one of the sort of founding fathers of quality of life research in prostate cancer 20 years ago that showed that physician report is notoriously terrible and underrepresents the magnitude of side effects of prostate cancer treatment. So it's really important to go to the patient and understand what the patient-reported outcomes are. So this is some follow-up work that we did where what we were trying to do was characterize typical trajectories of different symptom dysfunctions after prostate cancer treatment. So in this case, we're looking at urinary control. And this is your likelihood that after prostate cancer treatment, you are going to return to your baseline urinary control. And you can see that radiation, which doesn't in fact impact urinary continence that much, it's a very, very high likelihood of returning to your baseline control. But after surgery, if you make it to about 2.5 years after treatment and you haven't returned to your baseline urinary control, it's unlikely that you are going to continue to realize improvement. The concept behind some of these curves, and this is showing you curves for sexual function and for bowel function, is that in publishing these curves, we thought, well, gosh, we are creating these useful tools that not only patients can use, but also providers can use to counsel their patients. That the existence of these curves would somehow make care better or make communication between doctors and patients better. But we realized that that doesn't work. And there is a humongous gap between what we think patients should have access to and what they actually do have access to. When we started this project, we went to one of the local support groups and we asked a group of about 50 men how many of them had ever seen a prostate cancer quality of life survey. And 2 men raised their hands. And then we asked those 2 men, well, gosh, have you ever seen the results of your quality of life survey? And they said, well, no, we just filled out the survey and it sort of disappeared into this Raiders of the Lost Ark kind of warehouse. So there's a problem where if we want to create tools that are going to help men with prostate cancer navigate the side effects of the cancer itself or its treatment, we need to reconceptualize access to this quality of life data. So this is a design concept that emanated from several years of what we would say is user-centered design work. And that concept was this idea that we started with a simple question addressed toward prostate cancer patients. What are the questions that you yourself have about your prostate cancer-related quality of life? We then synthesized those questions into a design concept that answers 3 basic questions. One of the questions is, how am I doing compared to how I was before treatment? So how is my score doing now compared to how I was before treatment? The next question is, well, how am I doing compared to other men? It's one thing to have my own control, my own comparison to my own baseline health and quality of life. It's another thing to know, well, gosh, am I doing well compared to other men? Am I doing poorly compared to other men? And then the last question men had is, well, what can I expect in the future? If I'm doing worse than men like me now, can I expect to improve? Am I going to get better? Am I going to get worse? How can I generate expectations for the future? From this design concept, we did a pilot study, and we just published this pilot study a couple months ago. And the idea behind the pilot study is we exposed men to what we would call usual care. And unfortunately, in prostate cancer, usual care is really no access to quality of life surveys, no access to quality of life survey results. And then in a second visit, we had men interact with what we would call their quality of life tracker. And we found that, unfortunately, our doctors are very good counselors. So the max score over here is 5, and you can see that the patients felt like their doctor exhibited good communication. Patients were pretty satisfied with their interaction. Self-efficacy is this concept that you feel confident you can manage your health, and we had a particularly engaged group of patients. So one limitation of our study was we had a doctor who's a good communicator, and we had patients who were activated in their care. However, even in this setting, we found that patients who were exposed to this quality of life tracker discussed more aspects of their health, more aspects of their quality of life than men who were not exposed to the quality of life tracker. So how does this pertain to a concept of self-management? This is a conceptual model called the chronic care model, which is sort of a foundational conceptual model that's used in diabetic care, hypertensive care, and I would argue should be used in prostate cancer care. Even among men with more advanced prostate cancer, this is much more like a chronic condition than an acute care condition like a kidney stone. And you can see that in the chronic care model, a huge component of this is self-management. Now, in antihypertensive care, we now counsel patients that they should have some form of home blood pressure monitoring, even if it's going to Walgreens. But we don't really think about self-management that much in prostate cancer. A colleague of mine named Ted Scolaris did a great study on the information needs of prostate cancer patients. And you can see down here that some of the predominant information needs that prostate cancer patients said were important to them were clinical concerns, recurrence of their prostate cancer, but also the effects of the prostate cancer on themselves and the effects of the prostate cancer on their partner or caregiver or spouse. So understanding self-management of the side effects of prostate cancer is something that is truly really important to patients. If you look at the American Cancer Society survivorship guidelines, it's important to, as Dr. Wright noted, maintain a healthy weight. It's important to think about active smokers and referral for smoking cessation, but it's also really important, number one, to assess the information needs of our patients. So what are we doing with this? Well, we've crystallized what we would say is a design concept. And as Dr. Wright noted, several of us have funding from Movember. And what Movember is going to do is take this concept and broaden the reach of this concept to a broad population. So we consider this tool to have three important phases. One phase is understanding from our users, our patients for the most part, information about them, information about their cancer, and those patient-reported outcomes that help us understand the current state of their quality of life and the side effect impacts of prostate cancer treatment. We will then create these feedback reports like we tested in our pilot evaluation that we know help inform patients about the different domains or aspect of their health. And then in partnership with this gentleman, Ted Scolaris from the University of Michigan, we will then output self-management content so that if our feedback report tells us you have bothersome urinary control, we can give you self-management content targeting that. Now that's phase one. Phase two is going to take that concept and gather information from the users so we can understand not only how you're doing compared with men like you, but also what self-management strategies worked for men like you. So the idea is to create a tailored and personalized tool not only for presentation of data, but also for delivery of self-management content. And what's cool about this project is rather than being a local effort, which is what this project has been for about 5 or 6 years, this is going to be implemented at 15 sites across the United States with direct clinical implementation of this tool, and we're scheduled to launch in early June. But as importantly, we are going to be able to access a population of advanced disease patients that includes patients from Brazil, patients from the UK and Europe, patients from Australia, and patients from another foreign country, Canada. So when we think about how a tool like this can also help us understand how to make care better, we think about survivorship trials in prostate cancer. And if you look at a lot of lifestyle studies, we see that more lifestyle studies were positive clinical studies than studies of, for example, educational initiatives in prostate cancer, behavioral initiatives in prostate cancer, or what we would call clinical enhanced care initiatives in prostate cancer. So there is still this huge gap in our understanding of how to address the side effects and self-management needs of men with prostate cancer. And this is where this tool can apply patient-generated data in novel comparative effectiveness research studies to maybe create new knowledge as well. So this is an article that has been a big inspiration to me from a website called Patients Like Me. Now, Patients Like Me was started by an Englishman who had a family member with Lou Gehrig's disease, ALS. And he was very frustrated by their access to data. It's a rare disease, but it's a terrible disease that causes enormous functional deterioration. So he started this website that includes patient-reported outcomes data, and what they learned in observing the data that people were contributing to this system was that there were a lot of patients with ALS who were using lithium off-label to try to stave off the functional deterioration of Lou Gehrig's disease. So what they did was they started tracking this outcome using a functional status instrument. And this shows you that before patients were exposed to lithium, they were able to match patients who were using lithium to patients who were not using lithium by their functional trajectory. So that is basically sort of coaxing, I don't want to get Ruth Etzioni mad at me, but coaxing randomization out of observed data. And then they showed that after exposure, the patients exposed to lithium had actually a trend toward worse functional outcomes than controls. So they were able to do a very high-level comparative effectiveness research study using patient-generated data. So this tool is not only a tool where we can learn from patients, but also give patients some content that helps them manage their side effects. We can also figure out what treatments, what initiatives, and what interventions actually work better. Thank you very much.
Nola, do we have some chairs we can bring down? Okay, so we've got about